Reese with the South Dakota State Medical Association, and just a quick note before we get started. Leave the phones open so that you guys can ask questions throughout, and you'll see on your WebEx screen that there is a chat area on that right-hand side there if you prefer to ask your questions that way, but we will also, of course, take questions verbally. And we ask that you place your phones on mute when you aren't speaking so that we can avoid that background noise. Excuse me, this presentation will be posted online at sdsma.org about a week's time if you wish to review the presentation. And now I will turn it over to Stacy with South Dakota Foundation for Medical Care to introduce today's presenter.
Good afternoon. As you said, my name is Stacy Fredenberg, and I'm the Communications Manager for the South Dakota Foundation for Medical Care. We're part of the Great Plains Quality Innovation Network, and we're excited to be partnering on this 10-part series of webinar briefs. Key patient care topics will be presented in 15 to 20-minute webinar segments highlighting provider and clinician perspectives while introducing corresponding resources and tools. Today's webinar will focus on population health concepts for managing patient panels and provide information on the impact of systems on a smaller scale. Changes can have a large-scale impact on day-to-day tasks, and our objectives are creating efficiencies by developing small-scale actions and identify simplified progress tracking options. So it's my pleasure to welcome today's speaker. Len Berg is a PAC. He serves as a clinical director for Horizon Healthcare and works to promote quality improvement throughout the organization. In addition to serving the Huron area in family practice, he also assists with implementing and incorporating the patient-centered medical home model at Dunes Valley Community Health Center. He was employed by Horizon for the past 5 years and graduated from the University of South Dakota in 2010 with a master's degree in physician assistant studies. Len, please begin your presentation.
All right, Stacey. So today I'm going to be talking to you about the impact of systems on a smaller scale, specifically with the provider-nurse team. So, there we go. So the objectives here, number one includes creating efficiencies by developing small-scale actions, and two, identify simplified progress tracking options. So it was important to actually define systems first before we start. And systems include an interdependent groups of items, people, and processes with a common aim. And within a healthcare organization, this can be divided into clinical settings and administrative settings. So within the clinical setting, you can see there are a large number of players within that clinical setting that all kind of interconnect together. And then on the other hand of things is the administrative system. And when we bring these two components together, we have a large healthcare system. Training last year in Cambridge, Massachusetts, quality improvement coach training. One of the quotes I thought was particularly interesting was, every system is perfectly designed to achieve the results it achieves. So we might have a system that performs very high, and so that system that performs high is perfectly designed to achieve those high results. Whereas if we have a system that has poor results, that system is perfectly designed to achieve those poor results. And so what I'm trying to say by that is that a system has many, many moving parts, many interconnecting parts, and improvement can be difficult when trying to identify where we are trying to make improvement upon or where we are trying to change the system. And improvement requires change, but not every change is an improvement. We might take a step forward, we might take a step backward, but change is very, very difficult. So I'll be talking to you about some things that you can do as a provider nurse team to make change. So model for improvement. And they ask 3 key questions. Number 1, what are we trying to accomplish? Number 2, how will we know that a change is an improvement? And number 3, what change can we make that will result in improvement? And what you can see there with the last question, we actually put our PDSA cycles to test to see if we are actually making an improvement based on the change that we're trying to test. We need an aim statement when we're trying to test something within our system. And so making an aim statement, it's important to include the whole team. So this includes subject matter experts, the clinic staff, the admin staff, the patients. A variety of different people are included within this aim statement. And for the aim, we want to identify what we are trying to improve. We identify a goal and say, how much do we want to improve? Important to include time. When do we want to achieve this goal by, and where? So which clinic are we trying to target? Which provider are we trying to target? And then lastly, who's responsible for this change? It's March. March is my birthday, and so I'm really happy about that. But it's also colorectal cancer screening month for the month of March. And so I'll be using a recurrent example regarding colorectal cancer screening. So for our example aim statement, provider A will increase colorectal cancer screening, so I'll use CRC for short, screening rate to 80% by December 31st, 2017 by working with the care team. So you see I have all of those components of a good aim statement there. So you can see all the components are listed right here in this aim statement. Are we trying to, what are we going to test? What are we trying to accomplish, or what change can we make that will result in improvement? And so we want to know knowledge. And knowledge includes the data and the theory together to provide that knowledge. And so data, that can include a line chart, it can include a run chart, control charts, per charts, histograms, frequency plots, a number of different things that you can use for data. But we're using this data for improvement to obtain knowledge. As far as it goes, this is where we include clinical staff, admin staff, patients, subject matter experts. This is what change we're trying to prove that can produce knowledge. So when we're about knowledge, we're developing a sustainable change, an efficient change, and an effective change. So we're using the theory, the change that we think will make a difference, using data to produce knowledge. Not all knowledge is a step forward, it might be a step backward, but step backward tells us that maybe our theory isn't working. So in Horizon Healthcare, this is actually an aim statement, or one of the measures that we measure on a monthly basis, and this is colorectal cancer screening. It's patients aged 50 to 75 should have CRC screening documented in the EHR, including a colonoscopy, sigmoidoscopy, or FOB. It's listed here. Our current rate is 48%, and our goal for 2017 is 50%. So you can see here from year to year to year to year, we're actually steadily improving. The slide here represents each provider and how they're performing on their CRC screening rates. So R represents a provider. We have some high-performing providers. We have some lower-performing providers. Copy and paste on this slide is actually our rate for 2017 goal. So whenever you're displaying data, it's important to display the rate and the current goal. So there should be a line right around the 50% mark and the 50% mark. Also here that our data is in ascending order. So the different providers, there's actually, the provider names are listed. I didn't list them here. Provider names, the providers can see each other provider and how they're performing. So it's an important piece when you display data among your providers and nurses and care teams. So developing action and change. So here we can use this data as a driver for education and change. So these lower performers will see that maybe their colleagues are performing higher, and so they'll probably be more apt to improve upon their screening rates by viewing this data. staff and re-education. It's important to continually educate staff and re-educate staff whenever introducing change within an organization. With a given year's time, you might have staff turnover, so it's important to educate the new staff, then re-educate staff that's been there for a while. So review the data with the providers, nurses, and care teams, see how well they're performing. And then lastly, it's important to constantly educate the patient and educate the patient. So what I mean by this is always providing that type of screening at every visit, not only at their year visit or their 6-month visit or their 3-month visit, but every visit. So persistence and repetition, we actually create a culture for that change. Some material that I shared with the nurses during a nurse meeting last week just includes some education and re-education for the nurses. So here's an example of what you can use within your own clinics. Again, education. So when we review the data, we can identify champions and try to mirror the champions and help identify trends in the lower performers and help them improve upon that. I want to display data for all staff to see, and then again place the mean and median line. So when we have that data, we can actually use it to create action and change process. And examples that I'll give to you is root cause analysis, also known as the 5 whys. Here's an example that I've seen within the clinic that I work at using root cause analysis and colorectal cancer screenings. So the dot there, that's the quality improvement coach talking, and then the hyphen is the provider talking. So see your screening rates are 54%. Why do they are 54%? Well, I was at 60% a few months ago, but not 54. Why is it? I've been really seeing a lot of patients. Why are you so busy? Because it's cold and flu season. Why is it to obtain screening during cold and flu season? Because a lot of patients don't want to be bothered about CRC screening when they are sick. So you can see here, I've asked 1, 2, 3, 4 whys already. So we have to ask 5 whys. So why don't patients want to hear about CRC screening during a sick visit? They feel sick and they want to get better, plus harder to find time to discuss CRC screening when I have patients on my schedule. Plus, I have a new nurse, and she is learning everything else. I'll tell them at their next visit. So we can create a number of different action items on the 5 whys or the root cause analysis. So in rural South Dakota, we have many times limited resources. So we maximize the available resources we have. The idea is to create a workflow within the organization regarding a certain measure or outcome. You can create an order to allow other non-provider staff to discuss screening with patients. And we actually have a standing order for rectal cancer screening within our organization. You can provide education and culture in clinic to ask at every visit regarding CRC screening. So again, we go back to the culture piece, creating a culture for change. So before we test something, we need to know what we are measuring. Measure needs to be clear, concise, so everyone knows what we're measuring. And a measure includes individual parts or steps in the system. And this can be an outcome measure, it can be a process measure, it can be a balancing measure. So with an outcome measure, this is the end result. So in this case, it's CRC screening. This measure, on the other hand, is the individual action or step that we can change and measure that might affect the outcome in the system. And instead of measuring this on a monthly basis, this should be measured on a daily or weekly basis. By measuring on a daily or weekly basis, we obtain more data that can be tested for change. And then the balancing measure is a measure with unforeseen outcomes. So is moving one area having a negative impact on another? Test some thoughts here regarding colorectal cancer screening. So example is, clinics are performing better screening rates than others, but the busiest clinics. So a test here is, will who initiates the CRC screening recommendation have an impact on the outcome of CRC screening rates? This is where we can use jelly beans, and we used a lot of jelly beans within our clinics for other things, and it actually creates a competition within the clinic for positive change, and it lightens the atmosphere for change too, so you get more staff buy-in by doing this. Anywho, what we want to do is create two. We want to give a jelly bean for a provider that can initiate CRC screening with an eligible patient. Give a nurse a blue jelly bean a red jelly bean whenever she initiates or he initiates that CRC screening. And so at the end of the day, you tally and mark how many screenings the nurse has initiated or how many screenings the provider has initiated. And then you usually run your PDSA cycles. And so that's actually your first PDSA cycle. So this is what it looks like when you identify the data and you plot the data. We have provider A and nurse A here in this column, and then provider B and nurse B in this column. And you can see this, the data is somewhat hard to look at and somewhat hard to identify. So we plot on a chart or plot this data. It's actually easier to see. And that provider A is actually initiating more screening than the team 2. We see that the nurse B, is screening than provider B. The root cause analysis. Why is team 2 provider not screening as much as provider 1 care team? It is getting the nurse is getting the screening done. So why is getting the screening done? The provider gets to ask all the time. Why forget? Because too busy, but the screening's getting done, right? So we don't worry about it. Well, a few weeks go by, and team 2 nurse goes on maternity leave for a few weeks, and that provider's screening rates fall. So, and we get the answer is provider forgets to ask. So, what the things or what types of action items can we do to help remind that provider to improve screening rates? The idea is actually place the fit kit on the exam table to remind the provider to ask and measure daily. And if that nurse is putting an actual fit kit on the table, the nurse is in the habit of identifying which patient needs CRC screening or not. So do actually a couple of things at the same time here. And so this is your second PDSA cycle. So all that you can do, you can create a database, of course, which creates a monthly database for everyone to see easily, including nurses and providers. With the database, as we mentioned in the previous chart there, who is meeting the goal outcome measure and who is not, and this drives change. And then within a patient database, you can actually identify which patients are getting the screening done and which ones are not getting the screening done, and identify trends accordingly. So this link is a nice link that you can go to, and you can look up some other quality improvement tools, other ways to use data to help with your quality improvement efforts. That's all I have for today's session. Do we have any questions?
Question. Do you, does the medical personnel, the physician or the nurses, use data such as a family history for colorectal cancer to focus more closely on those patients?
Sure. So during that we performed, we specifically talk about average risk and high risk. So look at the slide here, if average risk, we begin the screening at age 50, and we give that patient different options, whether it be a colonoscopy or a stool-based test or other screening method. They're higher risk, and so that includes family history of colorectal cancer. If they have any type of higher risk condition, we make it very clear and we educate our nurses and staff time and time again that they actually need colonoscopies and should not be a candidate for a FIT test, but a colonoscopy beginning at an earlier age than 50. So that's an important part of staff education that we constantly go over with staff, and we actually have a list of questions that we provide for the nurses so they can ask those questions to patients if they had a prompt in front of them. So we're screening appropriately based off of average risk or higher risk.
I have a question.
Sure.
Able to do an end result analysis to see if this kind of intervention actually results in reduced deaths from colorectal cancer?
So that is something that we do not measure currently within our organization. So as far as analyzing that, we have not done that. If that's something that we could potentially do in the future, I would hope so that we could do that, but that's something that we don't really measure within our organization.
Yeah, because you had that, if you had an analysis of that type, I think that would strongly motivate patients to accept colorectal screening fully.
It's a good.
And this is Stacy Fredenberg. Can you talk about, besides the jelly beans, have there been other easy tracking methods that you use that you found helpful to make these quality improvement processes go smoother and be less cumbersome for your staff?
So I think the easier the better, the funner the better, because you have staff buy-in. I like the jelly beans idea. We've used beads before, different colored beads. For instance, for meaningful use, there's a measure there about patient portal and signing up patients for patient portal. And so we actually developed care teams. We developed 4 teams within our clinic.
No, I don't know. Let's see, when is she here next? She won't be here until Monday. She's on nights the next 2 nights.
Just a reminder to mute your phones, please, if you're not asking a question. Thank you.
So for meaningful use, we developed 4 different teams. And so on the team, it would include an interpreter, it would include a front desk staff, a nurse, and a provider. And so depending on who on that team got that patient signed up for a patient portal, they put in a bead into the jar. At the end of the day, we tallied up each team, and then at the end of the month, we're able to identify which won, and then they got a prize. And doing some little type of incentive or some competition within your clinic is also a key motivator. Other things, having weekly staff huddles in the morning and just giving praise to those higher performers and saying good job. Something as simple as that can really go a long ways and motivate for change. I'm involved in a diabetes quality improvement effort last year within our clinic here, and actually educated each provider in how well they were doing regarding a measure around diabetes. See greater than 9% percentage of patients, and we did see a slight fall in those numbers, and that actually more attributed to ensuring that the patients got in for their regular visits And that's what we found out during that little piece of quality improvement, that a lot of patients, they simply weren't coming in for their appointments just because they reminder to come in for their appointments. And so we had, send letters or do phone calls or more phone calls to get them into the clinic. Things that I've done in the clinic is actually make cue cards. We have all these different measures that we do. We do mammogram, we do CRC screening, apps, and so I have these cue cards that we can actually give the nurses or have the nurses, pre-screen those patients, that to the provider to remind, hey, we need to talk about this measure, or we need to talk about this measure. And you can actually place that cue card on that table to remind that patient that piece of, screening needs to be done with that patient. So that's another idea that we've encountered. As far as tracking that, you could track that again with beads. You could track that with a run chart. So a couple of different ideas there.
I want to remind everyone, too, that this is the first in a webinar series, and the next webinar will be held 2 weeks from now on March 28th. Dr. Heineman will be presenting on the impact of data transparency and becoming a provider champion in his webinar about where do you rate. So please register for that webinar. If there's no other questions at this time, we will close out. Thank you so much for sharing your lunch hour with us.
Thank you.
Thanks.
Thank you, everyone. I should have been typing that sooner.